Hello and welcome everyone to Psych Group's fourth event this academic year, entitled What is Individual Cannot Be Explained in Terms of the Other, Reflections on the Phenomenological Psychiatry of Karl Jaspers. This is a talk by Dr. Aicha Rifai. Now, I find it difficult to do an introduction without making it boring, so I'll just do what I usually do in situations like these and try to explain why I think this is a very important talk. Now, in the case of a psychiatrist or a psychotherapist, before one goes about speaking to the psychiatric patient, diagnosing and treating them, there must be a certain conception of what mental well-being is. And the simple answer to this is that mental well-being is defined negatively. It's the absence of symptoms. It's the absence of social impairment. It's a kind of behavior that does not deviate too much from the average of that person's culture. But what I'm saying is that beyond that, there's an underlying philosophical understanding of the mind implicit that sustains a psychiatrist's practice. And these vary widely and they translate in different kinds of practices. For example, it is one thing to say that reality simply is. It exists irrespective and external to us. And it is another thing to say that reality is produced by our consciousness. The latter connotes a more emphasis on the agency of the individual. It lends more importance to the subjective experience. It has a more active role. And one school of thought that very much accounts for the importance of the subjective experience is phenomenology, which Dr. Rifai will be talking to us about today. And Dr. Rifai joined WCM-Q psychiatric faculty in 2016, and she has an interest in the history of psychiatry. And no one is more fitting to be giving this talk here today than Dr. Rifai. So let's give her a warm welcome.
Is this working now? Yes, I think so. Thank you for inviting me to talk, and I hope this will be of interest in general. We spoke about phenomenology on the day when Dr. Sharkey made his presentation that I called anti-psychiatry. And I told him that I think anti-psychiatry belongs to psychiatry. They are together, and we need each other, because what would we do anti-psychiatry do without psychiatry, and vice versa. And I mentioned phenomenology as a school that's going, that is going in the absolutely opposite direction from the descriptions that we heard from Dr. Sharkey. And this is a rich tradition. It's a continental tradition coming to us from Europe. And while Karl Jaspers is a name in the United States as a psychologist and philosopher, his contribution to psychiatry is not as well known. So I'm going to talk a little bit about him and about his psychiatric contribution and what's happening with that in terms of its rediscovery. And we'll see what happens. So this picture, I'm sure many of you have recognized the Guggenheim Museum in New York City. And it's a picture that was recently published in the New York Times advertising the retrospective of a painter, Agnes Martin, who passed away in 2004. She is an American abstract painter of immense power to me and to evidently the people who felt it was worth a retrospective. I thought whenever we talked about having this poster for the presentation, immediately Agnes Martin came to mind, because her paintings are minimalist. They just give us a very simple presentation and the longer you spend with them, the more their power comes about. I'm not going to spend a lot more time on Agnes Martin. I also liked very much the way we had a double perspective on the paintings through the rotunda. And the issue with phenomenology is multi-perspectives. And that's the other thing that this picture meant to me. We have multiple perspectives on a human being. So let's start. At the moment, this is how it's called, psychiatric phenomenology, philosophical psychiatry. There is a chair of philosophical psychiatry in Heidelberg, Germany. There is a chair of Karl Jaspers psychiatry in Oldenburg, Germany. There is nothing like that in the US. The question is, I want to go back now, and we always are talking about how did we end up with DSM? Why is now psychiatry DSM, and so everybody can criticize psychiatry? And then the other issue, how did Karl Jaspers attempt to move the method of psychiatry beyond the third-person descriptive approach and enter us into a richer experience of our patients? These are biographical sketches. I want to stress this. Jaspers felt that the human being in his life had to show who he was. The life, the biography, is what finally tells you who a man is. And in his autobiography, this was consistent. And in his assessment of his contemporaries, it was something that he always took in his consideration. It was as well in his assessment of patients. So biography is not just facts. It's really a person, a life, a subjectivity intertwined with time. He was born in 1883 in the city of Oldenburg in northwest Germany. Was lucky to be born in a family where he describes his father as a very rational, supportive man who, from a young age, supported his independence of thinking. And he himself gives examples how he supported him, for example, in school against authoritarian thinking. He grew up in a very positive environment. However, he was ill. And for a number of years, his illness was not diagnosed until he was finally diagnosed in his adolescence with bronchiectasis. So for those of you who know, this is a chronic disease of the bronchi. And at the time, of course, they didn't have antibiotics, so there were lots of homeopathic and manual exercises. It impacted his life, but it made him relieved because he knew where his limitations stood. Nonetheless, he had a full life. He graduated from high school, started briefly law school, then decided to go to medical school, went to Heidelberg, which he enjoyed very much. It was a center for neurology, neuropathology. At the time, he was in a very rich environment, and he thrived there. During his residency, his chief of department was Nissel. For those of you who have done neurology, pathology, you know Nissel stain. That's why we know that the endoplasmic reticulum is bluish colored because of the Nissel stain. And before him, Kraepelin was in the department, and we'll talk about Kraepelin's significance. In his fourth year of residency, he asked Nissel if he could sit down and write a textbook on psychiatry, because he saw that there were lots of theories, but that the patient really ended up not having that much benefit from what was going on, that they needed more consistency, that more science needed to be done within this type of system. So Nissel allowed him to sit down and write a book which ended up becoming a major textbook of psychiatry called Psychopathology. It is still available. He kept reviewing it until his death, and there is a posthumous edition that came out in 1973. It's an exquisite textbook, which I recommend to you. It's translated in English, 2-volume, paperback. It's very important to review and read. After this, he became interested in psychology and wrote a book on psychology and worldviews, reviewed all the field of psychology. He finished that, and he had become interested in philosophy already, and he wrote many books on philosophy, reviewed history of philosophy, and became a professor of philosophy at University of Heidelberg without ever having studied philosophy. During the Nazi time, he was demoted from his professorship because his wife was Jewish. And it was between 1937 and 1945, he was forbidden from teaching and publishing. So he sat down and they made a pact that if they came to take her to a concentration camp, they both will kill themselves. They had cyanide tablets. Fortunately for them, in Heidelberg, the Americans entered Heidelberg April 1st, 1945, and actually they received in the mail the paper for her to be transported to a concentration camp. So that was a very important period of his life. After the war, he became very active in the history of morality. He wrote about German guilt. He took positions against a lot of people who had been cleaned up, denazified, just to make the society go on. So he had a very loud voice in how the German Republic was going, and ended up very dissatisfied. It was at that time that he moved to Basel in Switzerland, and he continued teaching there until he passed away. So political and ethical philosophy were his last involvements. In the psychiatric context, and I want to talk about him as a psychiatrist, the people who were present and active and whose ideas were very prevalent at the time were Griesinger, Meinert, Wernicke. They all believed that psychiatry is basically a disease of the brain. All mental illness is a biological illness, and that's all. So he called that biomythology. On the other hand, Freud and his circles had a theory, had a method which they applied in his own mind without really taking into consideration the reality of the patient, his subjectivity. They just applied it and got information, and he didn't think that that was really just enough, that deep psychology. And his idea was consistent until the end of his life. And then there was Kraepelin. I'm sure you have heard of Kraepelin. I hope you have. We live in psychiatry in a Kraepelinian world. The reason we have DSM, World Health Classification, is because Kraepelin was fanatic about systemic classification, and his classification survived more than anybody else's. There were others, but his is the one that survived. He put emphasis on signs rather than symptoms, and on grouping of signs under clinical entities. He basically was the one who looked at all the psychotic patients and said, okay, these look like they are getting worse and progressively worse. This course looks like it is on and off, cyclical. So he divided the psychosis into two big branches, what's called the Kraepelinian dichotomy, and basically, he called them dementia precox, which eventually was changed by Bleuler to schizophrenia, and manic depressive insanity. At that time, the Wassermann test came about to test for syphilis, and some of those patients were removed from these categories, and they were trying to clean it up. They were trying to systematically come up with categories. Kraepelin had a third perspective view of patients. He looked at what symptoms he could see, what was reported in the police report if a patient was brought in, what was the family telling, but he did not really talk about the patients. And there's an archive because he moved to Munich after Heidelberg, and his work is archived in Munich at a Rockefeller Foundation, and it is something to behold for documentation. It's really a good thing to see. He wrote the Compendium of Psychiatry, which is a very dry textbook which was never translated into English. But we inherited the dichotomy of psychosis, and we stayed with it. What was the philosophical context? Plato had basically talked about, in trying to define the possibility of knowledge and of what can we know, what is in the world, he came up with multiple allegories, multiple explanations, but essentially what idea of idealism comes from the notion that there are realities that we are born with that are always present. These realities are like justice, beauty, and they are within us. What we see in the world are manifestations only, appearances. We don't see the realities themselves. So this is very briefly what the concept of knowledge, what can we know? And that is something that was crucial for Jaspers as he was developing his theory. What can we possibly know? This is Plato's allegory of the cave, just to illustrate what I just said. Many of you have heard of it. Part of it is relevant to our talk, but because if it's a picture, I thought we would put it. You see, we are the prisoners. Okay. We are the prisoners sitting here. And this is really reality. And this is diffuse sunlight. So it's just throwing shadows here. And because we are prisoners here and our necks are bound, we can only see this. And we think this is reality. And it's appearances. And that's what Plato called phenomena. While these are forms, ideas. And this is from the Republic, but the rest of this allegory is not relevant to us. But this is one explanation, one way of explaining that theory, which remained extremely important throughout the 20 centuries until Immanuel Kant. Everybody talked about phenomena, about eternal realities, but it was really Kant who basically came up with a theory of knowledge and said, we have no way of knowing the true realities, the pure, the good, the just. That knowledge is not accessible to us. So he calls them the noumena, the thing in itself, the independently real. We need not make, because in his time there were lots of philosophical debates between the rationalists between the people who were more metaphysicists, and there was no clarity on what can we know. He decided that the noumena were not accessible and we should stop looking into them and we should concentrate on phenomena. However, what he added was that phenomena were accessible to us with sense perception as well as reason, that reason can give us phenomena. His other questions, which form the beginning of what's called theory of knowledge, are how is thought related to an object? What happens in cognition? These thoughts were all very important as Jaspers was thinking of his approach to patient, of the theories that he wanted to explain these issues. What can we know about the person in front of us? How do we know what we know? Same thing with Husserl. Husserl had a very important role to play also. But we have to be careful because Husserl had 3 phases of his theories. And it's only the first phase, which is called the phenomenological reduction, in which he says, the epoche, in which he says, when we approach a thing or a person, we have approached them without a theory, without a prejudice. We have to have a direct intuition, not in the sense of intuition that we think about it as a momentary, quick idea, but as an apprehension of the other, and he thought that this was the principle of all principles, the highest, that we have an ability to know and to see as strong as the other perceptions and senses that we have. So this part is what Jaspers took from him. And you will see, and this intuition, as I wrote, is representation without need for construction of knowledge. It's direct. You look at someone, you know something about them because your ability, this ability that we all have, has become so developed and needs to be developed. There's a lot of scholarship now that's discussing whether Jaspers and Husserl were actually theoretically related, but I just wanted you to know that. Max Weber was a historian and a sociologist and very important in the life of Jaspers. He was very interested in methodology, in sociocultural sciences. He was talking about subjective knowledge, objective knowledge in the human sciences, and he talked about empathic understanding. Empathy was a notion in German human sciences, but he was somebody who was trying to make it into an application. So those were the influences in the background. So Jaspers himself defined his phenomenology as a method, as a study that describes patients' subjective experiences and anything that comes within their minds or their awareness. They are data of experience, and they're not obtained through the methods that we, obtain, measuring, asking, observation. They are accessible to us. This is what you wanted to say. How are we going to access these data that are not normally accessible? So I just wanted a quick illustration. This is the descriptive third-person model where a person looks, there is the psychiatrist, there is the patient, what's wrong with you? This is what we get. It's the outside, presence. This is the traditional psychoanalytic model, and Freud, the ego psychologist, he felt that they had a grid applied, that the person behind them was no longer, you could no longer see that because everybody had, either an Oedipal phase and conflicts of this or that, or the defenses, but it was not subjective enough. And this is Jaspers and a patient, and you will notice that there is both ways there is interchange, but most importantly is the area in the middle also, not most importantly, but also in this model, he started talking about intersubjectivity, what happens between two people, not only from one to the other. And now we talk a lot more about intersubjectivity, verbal, nonverbal communication, relatedness, education, and empathy. What is psychopathology? He differentiated between clinical psychiatry and psychopathology as a science, and he dealt with the question of our access to knowledge of the other. We can observe behavior, listen, read reports, but how can we gain a more direct access to the other's experience? His contribution was changing the observational point of view, spending more time with the patient, studying the process of development of illness from premorbid traits, and application of the phenomenological reduction observation, atheoretical, prepositionless. I'm going to pause here and read to you a case that he wrote early on, a patient of his. Julius Klug, a watchmaker, came first to the attention of the law. He told the district attorney that his wife was unfaithful to him with a number of men. He felt wronged, not ill, and therefore doctors were momentarily absent from the scene. Klug asked for a divorce and was instead referred for psychiatric help. Typically, there followed threats, protests against the imputation of illness, requests for legal help, a continuing preoccupation with his wife's alleged adultery, and a voluminous correspondence with the authorities. We know patients like him who become extremely legalistic and defend themselves. So this is the outside description of this patient. This is how Jaspers would approach the patient. The patient himself described how after an unsatisfactory party, he heard a noise as of a door opening. He felt a wet cloth over his face, then caught something like whispering or a kiss. There were feelings of bodily movement and pressure. This was not a dream. The impression was too clear, in his own word. Yet, he might have been half asleep. The last points are vital. Those are called the elementary experiences of, in the nucleus of psychosis that the patient is describing. Later on, Jaspers takes us directly to the patient's written accounts, which were also later on supplemented by an autobiography which the patient wrote. They emphasized the unexpectedness and severity of the evening's hallucinatory experiences. The latter were worse than, quote, unquote, quote, the worst of murders, end of quote. In the morning, he believed himself poisoned at breakfast, heard a roaring of waters, and had more physical discomforts. So, when we look at how, when you see a patient in the phenomenological psychopathology, there is the application of two ideas. One is understanding, and which includes the psychopathologist transposes himself in the patient's experience, experiences what the patient is experiencing, makes present to himself the experience by examining it as if he's experiencing it, immerses himself in the experience of the patient, explores the patient's experiences through exploration, and reviews written reports of the patient's own experiences. This understanding is described as rational and empathic. not only is he understanding the patient who sits in front of him, but also understanding the psychological causes that might have led to this. That the patient is angry now, but what was before? That's the meaning of genetic before. And here, the use of Husserl's intuition. There were, of course, critiques of understanding. People were, he was feeling that the method provided precise and reliable data that could be not only relied upon, but also could be communicated and debated. Critiques were critiquing the precision of intuition that he was claiming, but he felt that sense perception also can be misleading. We are not always 100% seeing what is out there, hearing what is out there. There is no 100% reliability. So the intuition is no different in that sense. And other people felt that it was counterintuitive for a doctor to see a patient and work with them without having some prejudice, an enabling prejudice. For example, when you see a patient, you look at them, right away you think, okay, the patient is not well dressed and he's not taking care of himself. He looks either depressed or psychotic, just like that. He felt that some of these, this is how we work, but he felt that some of these ideas were disabling and we should have a fresh look every time because we're already going into dead ends. But they are, you know, we would have jumped to those same conclusions too. The second thing, besides understanding, is explaining. He looked into biological causality. He believed that most of the time it was complex causality. He was sure that eventually we will see a biological changes that would explain what we are seeing in patients, but that the fact that those biological changes are there, that does not end our theory of what is wrong with the patients. That's not the all of what is wrong. Of course, it's biologically mediated, but that's not the disease, that's not the problem, that's not the issue. So that's what he was saying, complex causality, intermediary causes, and also he talked about the role of interpretation of results, interpretation of causality. One important thing that he, for example, was the one to point out, which we always talk about, is it's not always, when a patient has a symptom, it's not necessarily the cause, the precipitating factor. It could be part of the already disease or problem. He talked about the importance of biographical study of a patient and said every good case history grows into a biography. So that's why I like to correct case histories, because I like reading biographies. So I'm looking forward to that kind of writing from you all. He looked at the inward unfolding of life as a unique development and felt that the psychiatric illness is not just one thing hanging out there. It's rooted in all the person's life aspect. He felt that when we describe and depict, we talk about a case, when we try to feel and inwardly engage ourselves with the unique individual as he really is, it's not only a case. This, I wanted just to talk about a little bit phenomenology and existential psychiatry as it refers to Jaspers, because he gradually moved on, as we talked about it, from psychiatry to philosophy, and he is considered to be an existential philosopher. But so you see in Psychopathology in the book that he is moving in that direction. He talked about Dasein, and Dasein in German means being here, being there, being in the world. This has to be drastically differentiated from Heidegger Dasein. They are totally different concepts. Basically for Jaspers' Dasein is just being here, living, and not necessarily a great life. It's a life with unfulfilled potentialities. Suffering, guilt, and death are conditions of it. While existence is translated like this in English, is an authentic being. From Dasein to existence, you can move through transcendence and freedom. So this is a slide that shows Dasein as opposed to existence. It's called living in two levels. And he felt that people had limit situation. He described what's called limit situation. Limit situations are situations that take us to a very, to the border of what we can cope with. So in the limit situations is the opportunity to move to a deeper level, to jump. So either the person jumps and grows and enters into a better level of existence or develops symptoms. We see that in patients with borderline personality disorder, for example, having crisis, and what the possibilities are for them in terms of their coping skills, their management, because they have many Grenzsituationen, limit situations. A patient who has, let's say, agoraphobia or social phobia, when they are put in a position where they have to be in a place where they cannot cope with, if they can make the jump, the freedom that they actually have to move to a different level. And his psychology is extremely fascinating and has entered into existential psychotherapy. So the impact of general pathology and Jaspers. General pathology had limited influence outside the German-speaking world. And that comes from a few things, for a few reasons. It was World War II. Germans were looked upon negatively. It was not exciting to translate books from German. On the other hand, at the same time that he published General Pathology, one of his colleagues, Wilhelm Meyergross, who was Jewish, moved out of Heidelberg and went to England. And he became a great psychiatrist at the Maudsley Clinic, did a lot of publications, and he wrote a book called Clinical Psychiatry. It's also in Phenomenological Psychiatry. It's a great book. The last edition is in the 50s, and you can buy it used. It's again the same level of description of patients, but I think Jaspers is still better. So also what was important is that Jaspers came into conflict with a lot of his contemporary philosophers, and because he was a lot more moralistic about how things were going, while the new German philosophers wanted to move on. If one looks at Gadamer, Habermas, you see that they were no longer that attached into moralistic philosophy. They felt he was a bourgeois thinker. We didn't need to be thinking like that. And he entered into severe conflicts with Heidegger. Heidegger was the most important existential philosopher of the time, but Heidegger had been a Nazi sympathizer. Maybe some of you know, when he had become rector of the University of Freiburg a few days before Hitler came to power, and he remained in that position for 1 year, and he treated some of his colleagues very poorly, and after 1 year they removed him anyway. He had basically created a lot of chaos, but he remained in the Nazi party. So a lot of people, and especially someone like Jaspers, looked down on him. And when you read Jaspers' critique of Heidegger's work, he starts critiquing it on a scientific basis, and then he says, maybe I would have read more if I didn't know the man. But however, Heidegger became an inspiration to the new existential movement that did not care about Nazi past. So that was an influence. Anyway, I don't want to go on this. Now, in the United States, for the past 25 years, general pathology is being recognized. Articles have come up, especially from Slavny and Paul McHugh, who were both chairmen at Johns Hopkins. They are very interested in the multiple perspectives that Jaspers is offering. They feel that his option for conception of psychiatry is better than the so-called biopsychosocial model, which really is not a solid model. There is somebody in Boston named Gaimi, Nasser Gaimi, who has been also publishing on Jaspers. So there is a lot of interest in the United States in him. What's called the American Awakening. And I just wanted to finish with one of my absolute favorite poets, Thomas Tranströmer, who passed away a couple of years ago, Swedish Nobel Prize. Two truths approach each other. One comes from inside, the other from outside. And where they meet, we have a chance to catch sight of ourselves. Thank you. Thanks. Questions? Yes?
Yes, I have a question for you, Hind, here. So you talked about reality, and the picture you showed is very interesting because it looks like reality is coming from outside of the prisoners. It's taking place somewhere here, and it's reflecting in the screen. So this idea of the screen is interesting, but how about the prisoners? I mean, they are not by themselves creating the reality. Is the reality starting from themselves or coming from elsewhere? In other words, for us, reality, is it something that we create because we are conscious, just like maybe Abdelaziz explained in his, or presented in his introduction, or is it something that is there and we are looking at it? So that is my first question, and then I have another question.
So it's a very important question and very much relevant to our talk. The Greek view of perception was that the object sends rays and that enter us, and then we perceive the object. So it is, reality is outside of us. Immanuel Kant transposed that upside down and was the one who said, we make reality. In so many words, we perceive, we classify, we have things that we use reason for and things that we intuit, which is without the means of reasoning. And that includes time, space, arithmetic, and he came up with the categories and the causality and relationships. So that picture is from that time. Reality is outside of us. Yes.
So how about now? How do we see reality?
Well, it depends on how we all see reality. For example, there is a big current in Japan to say that the phenomenologists got their ideas from Zen Buddhism. That there is a book that it's clear that, for example, someone like Heidegger received in the late 19th century from Japan, and that really introduced that concept. I think that issues of reality, transcendence, the reference from what is coming to us from outside, what is our connection with something bigger than us, there's a multiplicity of positions on it. And there is no one answer to it. However, Kant was very interested in the concept of transcendence, totally differently from how we see it now. So,
okay, so if we bring back these to psychiatry and to the interaction, as you showed, between the patient and the psychiatrist or psychoanalyst, this is going to take a real big importance, right? And you said it yourself when, for example, you have the interaction between a patient and psychiatrist or a psychoanalyst. The psychoanalyst there has his background, okay, and he's bringing his background, his quote-unquote conditioning to the situation. And from what I understood, Karl Jaspers said that this shouldn't be like that. Should be looking to the reality, quote-unquote, of the patient naked from or outside of what is my background or my conditioning. And as a matter of fact, we spend every day looking to the other in this way with our conditioning. So I find that very interesting, but is there a recipe for us to get out from our conditioning or background to look to the other in a very different way, and also psychiatrists to look to the patient in a different way?
Yeah, I think this is really in the heart of the question. Let me just say that in the beginning, when he wrote about bringing the idea of the patient in, making them present, seeing them without prejudice, was, to my mind, a little bit early 20th century, still late 19th century, not the way we have understood intersubjectivity, much more mechanical in my view. However, with time, he himself started changing. And I'm glad you asked me, because I had typed those quotations and I forgot them. He said, "It is possible to partake in the inner life of another person through a tentative exchange of roles, a natural way of empathic listening to others in which we simultaneously keep touch with ourselves. Every psychopathologist depends on his power to see and experience and on the range, receptivity, and complexity of such power. This sympathetic tremulation, which is trembling, of one psyche with the experiences of another means that if we are to be scientific, we must objectify such experience critically. Sympathy is not the same as knowledge, but from it springs that vision of things which provides knowledge with indispensable material." At the end of his life, what he said is, from freedom to freedom, two free people, the analyst, psychopathologist, and the patient are interacting. There is an asking and searching in the historical concreteness of the situation, and neither any patronizing nor any making of abstract claims. So in psychopathology, there is a lot of talk in details about how to go about this. But in experience, it is the clinical training with people who do this, who teach you how to tune in, who show you how to tune in, how to get rid of these things, who show you tremendous insights that they can gather from this methodology and take you through it. So you do need the training. Reading a book about it is not all, and you develop in it. Did I answer the question?
Yes, so it means that there is some kind of methodology to get there, at least to get rid of certain level of conditioning.
I want to say this. I think that in terms of psychiatry, in terms of understanding, people understanding each other, our language, current explanations don't give us enough power to really express And that's why I continue to say we need a paradigm shift in the way we express things, in the way we understand them. From how do you move from concrete human beings to this very subtle explanation? Are we always going to be stuck with vague description, or are we going to have better ways of explaining it? How do you explain moving from biology to thoughts, moods? How? A cell, neurotransmitter, this and that. Great, but how is that going to explain mood? So language is not helping us, and the best experience is the clinical experience. When you are practicing this, you know what you are doing, and sometimes it's difficult to explain. Yes.
Thank you for your talk, Doctor. It was quite interesting looking at the history, and I'm interested in psychopathy personally, and I was wondering, since intersubjectivity, which is used these days, and it's kind of based on some sort of psychological relation between two individuals, in this case a psychiatrist and his patient, would you be able to apply this to, for instance, when you're interviewing a psychopath or an autistic individual?
I think that's a great question. And of course, already Max Weber, who already talked about empathy and subjectivity, and Jaspers both said within limits. There are situations where it's not applicable. It's clear. But what is very interesting, so psychopathy, patients with mental retardation, he mentioned them specifically, or patients with, at the time, hysteria, who are making symptoms, who are, unstable affectively. However, what is really interesting when you see, for example, that the patients who have psychosis and used to be felt inaccessible. I mean, there are lots of people who, don't do psychotherapy with psychosis. You ask the patient, you give them pills, and that's finished. There's a lot of literature on patients who do work with patients with psychosis with methods like these. And incredible people who have a lot of insight into these things. So it depends. I think you have to choose your patients, for sure. Any questions?
Thank you.
Yes.
I really liked the case study you provided about the patient who had external symptoms. And Jasper was focused not just on the external appearances, but also the underlying aspects in his life, which you called complex casualty.
Yeah.
So my question is, how does the field of psychiatry differentiate between the underlying aspect being just a part of human life and when it's an illness to be cured?
Great question. So in 1910, before he worked on general pathology, he described 4 cases of paranoia like that, Jaspers, and published them. 2 of those cases, he said the illness fell on the patient. No premorbid change. Patients had completely normal lives, nothing that he could see. He was certain that those were biological changes that happened and made it clear in his writing. On the other 2 cases, he saw how there were premorbid abnormality in the personality, how there were stressors happening, and how they went into the direction of delusions. And that was another question for him, is like, how come certain people under a certain stressor will develop paranoia and other people will develop some other type of symptom? So for us, this is what's called multi-perspectivism. We have to always be looking, what's happening here? What is the process? What kind of history am I getting? What is the suggestion? Yeah? So that's a great question which allowed for this you know, for this talk.
Thank you.
Anything else? Yes, Dr. Sharkey.
Again, thanks very much for that. It was terrific. So you're an anti-psychiatrist too, then?
Excuse me?
You're an anti-psychiatrist too, then?
Am I?
Well, let's face it. Look, you're contextualizing the talk largely in terms of philosophy. You're finishing on poetry. You're looking forward to the students' case studies, which will be as rich as biography. I have seen other people in the psychiatric field stand there who would dismiss all of these concepts out of hand and, you know, proceed from a neurobiological base. So, in that respect, you call me an anti-psychiatrist, so I'm calling you one too, but in the most affectionate way. Where then, I have a couple of questions, but I'll make them brief. Where does if Jaspers approaches the idea of the patient and the patient encounter in a presuppositionless way, that means then that he's not taking account of transference, or he's dismissed transference as an active concept. Is that correct?
Yes, he actually did address the issue of transference, and very clearly, and he refused the transference of in the Freudian sense. He felt that he recognized very clearly the influence of the real moment, was aware of other, you know, in terms of how the classic transference and how unconscious it is and all of that. But his position was that Freudian theory had taken the reality so much out of the question that he is no longer going to stick with that. However, it's very interesting, and there is somebody that I would very strongly recommend to you, whose name is Margulis. Alfred Margulis was written a beautiful article referencing Jaspers called The Uses of Wonder. And how within that perspective, the ability to be receptive, the negative capability of receiving the others, is even more inclusive than transference. So in Jaspers' theory, that transference was poor, and that's why he doesn't want it. It was not enough. Not that it was not correct, but it was not enough.
Okay, so in a more transcendent vision then. So, remember when I was talking about the importance of political context, and thinking in terms of a presuppositionless approach as kind of voiding context.
Right.
It's the case, I think, that originally Jaspers was on board with Heidegger's idea of Dasein until the Freiburg Address in 1933, when then Jaspers comes to an understanding that Heidegger's idea of the arrival of the moment is coextensive with the arrival of Hitler. And so then he makes this decision that his approach to Dasein would be a much more, how should we say, disengaged, lower expectation type of transcendence. So what I'm saying essentially is that he made a decision about the direction of his own philosophy based on the immediate political context when he saw that Heidegger's philosophy was coextensive with Hitler. If you see what I mean. I'm just making, I'm just sticking my oar in as well for the importance of
I'm not sure. I will say this. I'm not sure that that's exactly what happened, because actually when Hitler arrived, he was ready, Jaspers, to support that. He was not completely disengaged. So on the type of philosophical idea, he was almost going to go with it. The reason was that at that point he was still quite interested in Nietzsche. And Nietzsche had talked about, the freedom and freedom leading to the Superman. And he talked a lot about freedom. And so he thought maybe this was a way out. He has a lot of other justifications or why he didn't, in terms of theoretical philosophy, why he didn't go with Heidegger, which he documented. He felt that Heidegger was too mystical, that Heidegger rejected science, which he did not want to reject science very strongly from the beginning, and he kept up with it. He felt that the pre-Socratics had been kicked out of Heidegger's theory. So he listed a lot of very specifics. It was interesting because he wrote the document of several pages in case someone asked him to write his opinion about Heidegger, and it was found among his papers.
Okay. Yeah, autobiographical. So finally, then, lastly, why did Jaspers switch from psychiatry to philosophy specifically?
Within the years that he was writing psychopathology, between 1913 and 1917, he became more and more interested in philosophy. And Max Weber was right there, present with him, and they both, were reading Kant. And Kant was a major influence on him from the beginning until the end. Nietzsche, just for a period.
Thank you.
You're welcome. So I'm an anti-psychiatrist in your camp.
Yeah. Things are looking up.
We have now to define psychiatry if you and I are anti-psychiatrists. Thank you for the questions. Anything else? Okay. Thank you very much. We'll see you next time. Thanks.